to Anne van den Hoek. Everybody know the next speaker, ChristinaPuchalski. She's a professor. She's a palliative care doctor. She's a director of George Washington University Institute for Spirituality. And then, please, thank you very much.
Thank you very much. And I also want to thank the Academy for this amazing conference on palliative care. And at the break, I was asking Jim, have you ever been to a palliative care conference where the entire morning is on spirituality and spiritual care? So we want to thank the Academy for that very much. So it's my pleasure to speak to you about some of our work that we've been doing in the United States and also now beginning to do in other countries. And I changed my title a bit to Models and Partnerships, because as we've heard from most of the talks yesterday and as we've heard from each other at breaks, collaborations are essential. Interdisciplinary collaborations are essential in moving all of palliative care forward. So you've seen this already, I'm not going to go through this, but I want to highlight the perspective of spiritual in the WHA Palliative Care Resolution. Having been involved in something about 10 years prior to this, was an organization that worked with the WHO on person-centered care. That organization tried to include all those 4 domains in person-centered care and met some resistance from the WHO saying, we agree with that, but that may be too early to use the word spiritual. So again, I want to thank the WHO for taking the courage, and Marie-Charlotte, who led that effort, and many of the people in this room have been part of that, to ensure that actually now in the WHO documentation, WHA, that the word spiritual is there. And it's there in 3 places, including the mention of spiritual support and counseling or spiritual care professionals. So I want to start with this story. This is not my patient. It's an image of my patient. But one of my patients in my palliative care clinic, I run a palliative and supportive care clinic that is interdisciplinary. We have a chaplain on that team in the oncology, our outpatient oncology. And this was a woman who was diagnosed with metastatic breast cancer for the first time. She had never had cancer before, and it was metastatic at diagnosis with metastases to her hips that was causing tremendous amount of pain and dysfunction. And the reason she was referred to us by the oncologist is because, in fact, her prognosis was, relatively decent, could be several years. That surgery on her hip, while a bit aggressive, would actually improve her symptoms, and the oncologists were offering her that. But she was not willing to consider surgery or chemotherapy or palliative care or anything, and she wasn't keeping her appointments. So they thought that maybe coming to us and talking would be helpful. And in our first visit, and we interview patients as a team, we did a complete history. I did a spiritual history, and she said she was Baptist, things were just fine with God, everything's okay. And I thought, that doesn't quite sound right, didn't feel right in the visit. So I then did, as part of our review of systems, so the clinicians in this room will recognize that, asking some of the spiritual distress that I will later talk about, what we call spiritual distress diagnoses. And when I said, have you ever felt hopeless? Have you ever felt despairing? She broke down crying all the time, and nobody is listening to me. When she started that, her daughter was standing behind her, pulled out her cell phone, and started working on her cell phone. So her loneliness and isolation was palpable, and we, of course, explored that a little bit more, and she talked about being angry at God, really angry, really voiced anger at God. And during that session, and then over the follow-up visits where she came with the team, but also privately with the chaplain, privately with me, we all addressed that with her, but the chaplain had more skill, as Anne already beautifully described, in exploring other themes. About 2 months later after this, she came back into the waiting room and looked completely different. In fact, I almost didn't recognize her. She was light. She was, full of hope and joy. She did have the surgery. It went very well. Her quality of life is really good. She's on chemotherapy. Right now, she's doing very well. And she easily talks about dying. So it's important that these situations come up in the clinical setting, and so I'm very passionate, many people are, that everybody on the team should be willing to address this. So what is some of the suffering that my patients have faced and others have in serious illness? Meaning is a huge one. I'm not the person I used to be. And particularly with patients who are towards the end of their illness or in aging when they can no longer do what gave them meaning, that's a huge issue for them. Hope. What do I have to hope for? Mystery, the why me, why now. In fact, the patient I just talked about, after her work with the chaplain, she came back to me and she said, I really wasn't angry at God. It was just why me? Why did all of this happen to me? But I liked to take it out on him because I knew he could handle it. So it is a very, very common thing, and probably one of the biggest things that I see in spiritual distress is the why me question. Isolation and helplessness, inability to control life. Eric Casal has written about this notion of a transcendent dimension, and he says that everybody has a transcendent dimension, a life of the spirit. The quality of being greater and more lasting than an individual life gives this aspect of the person its timeless dimension. And then his last sentence is very moving, particularly since I also see patients in nursing homes. When I see patients in nursing homes who have become only bodies, I wonder whether it is not their transcendent dimension that they have lost. And I think this is such a poignant expression of what happens if we ignore the spiritual dimension in patients' lives and their deep suffering as people are sitting there with that suffering not being attended. I think I borrowed the title from Catherine Pettis when she talked about a global pandemic of pain. I think we have that in spiritual distress as well. And here are just some studies, and there are many others, measuring spiritual distress in cancer patients in the US and Switzerland with patients in HIV and also in Zimbabwe. And you can see that the frequency of spiritual distress is quite high in different regions. So we have that obligation to attend. As the WHO resolution says, we have that obligation to attend to that suffering, that spiritual distress with patients. Healthcare professionals have that obligation. One of my medical students, Parna Sanji, is just finished writing a paper with me, and she took the stab at the first draft, and I was very touched by this sentence that she wrote as we talked about illness and why it is so important to address the spiritual domain, because it is a spiritual journey for people. And she wrote, "The implications are serious. To ignore the spiritual aspect of illness, especially with our large aging society facing chronic illness, is to ignore a significant dimension of that experience." And we've certainly heard that today on the panel from people and yesterday as well. Kathleen Dowling Singh wrote a book called Grace in Dying. And I love this quote because I think it describes what is the nature of spirituality, in particular when we are moving through distress or being challenged by illness. And she writes, "In dying, we move from chaos to surrender, to eventual transcendence. Initial encounter with illness and the prospect of dying can result in chaos. Surrender is when one is open to one's deeper being, that inner life that we have, that deeper being. Transcendence is going deeper into spiritual integration." So I think that this is a normal spiritual journey, what one might consider just normal issues. And over the years, I've had many discussions with theologians where they say, why do you have to medicalize spirituality? We'll talk about that a little bit. But not everybody can do this. Some people can actually go through this process, eventually the surrender, the way John of the Cross talks about, not giving up, but a real holy surrender and acceptance, and then moving deeper. But some people cannot. And the role that we all have is to discern, is this a normal part of this person's spiritual journey, and do they have the resources to move through this, or are they, say, stuck at that point of chaos and not being able to do that? And here is, again, working with professional chaplains, spiritual care professionals who can help us with that discernment is key. So how do we address spirituality, or how can we in the clinical setting? Well, if we look back at this quote of going deeper into spiritual integration, this is a huge piece of achieving wholeness, of being restored to wholeness. of being broken apart, say internally, by illness or the prospect of dying, and coming to a sense of wholeness. And maybe it's probably at a different level than the person was before that illness. The spiritual exploration can trigger us to ask many, many deep questions that may result in a reframing or a refocusing on what matters most in that person's life, a reprioritization. And so healing may occur in this setting if a patient is accompanied by the other. We talked so much yesterday, and the Archbishop talked about being the notion of accompanying patients on their journey. It is very difficult to do this journey alone, and anyone can accompany, but we as healthcare professionals do that within the context of our professional identity. It is our witnessing as healthcare professionals to suffering that healing becomes possible within that person that we are witnessing to. So the patient that I referred to at the beginning, she had no words. She didn't have words, I'm despairing, I'm hopeless. She didn't say that because the pain and the intensity of that kind of suffering, and it was palpable, it was difficult to witness. She had no words. But over time, our creating a sacred space, the chaplain doing that, we doing that, often in silence, that person is able to share that and eventually put their words on their suffering and come to some sort of resolution, perhaps. Now, I was very touched by the clinicians in the earlier part of the panel today who shared from their own perspectives. So from my own tradition as a Catholic and as a Carmelite, my understanding of this is very Eucharistic, and it is very much about witnessing and being in the presence of the holy or the sacred. And so my understanding for myself about presence is how do I recognize that sacred moment? How do I create that for the patient? And how do I connect and experience that union or contemplation that Teresa of Avila talks about in Lectio Divina, those occasional moments of great depth? And that's my personal understanding of this. But each of us need to find that from our own spirituality. And we did create a model, Joan Halifax and I, with a group at the Fetzer Institute, proposing that our own spirituality leads to our ability to be compassionate, to be able to witness. I'm not going to do a lot on data. There's a huge amount. Tracy Balboni and Karen Steinhauser, I was part of their group. They did a beautiful paper, 2 papers, summarizing all the current research, mostly in the US, in some other countries as well, on spirituality, religion, and health. I'm just going to highlight a couple that are frequently used and cited in the work. So from Tracy Balboni, looking at patients with advanced cancer, the importance of spirituality to cancer patients, you can see that for the majority, it's very important. There are many studies like this dating back to the 90s. Many studies where in pulmonary and critical care, in primary care, the majority of patients wanting their physicians in particular to address their spirituality with patients. And there are others in other countries who are finding similar results now. There are many studies on healthcare outcomes. Many of these are association studies, very few intervention studies, and we'll talk about that in a minute. But these association studies do show that spirituality and/or religion, and we'll talk a little bit about definitions, can impact quality of life, mental health, physical well-being, coping, adherence to treatment, and improve social functioning and maintaining social relationships. So again, critical role for spirituality. The one intervention study that I think is really well done by my colleague and my mentor, Betty Farrell, at the City of Hope Cancer Center, and she looked at it. So at the City of Hope, they were doing educational interventions for patients and families. And she tested in the experimental group, one of the 4 modules was on spirituality. In the control, they added some social issues to that 4th module. And what she found were that the outcomes in the intervention group in both families and patients was less depression, less anxiety, improved spiritual well-being, and improved patient experience. So what seems to be up to this point in the research in terms of outcomes around spirituality is that there is an association with less depression, less anxiety, and this intervention study is one of the first intervention studies, and this is the type of study we need. Later on, I'm going to talk about standards if we're going to justify the work. And it's challenging, and I know most of you in palliative care understand we also deal with that in palliative care. This is the City of Hope quality of life model, and I just highlight the spiritual well-being. This is their model and the questions that they ask to measure quality of life. And you'll see in spiritual well-being, meaning, uncertainty, hope, religiosity, transcendence, and positive change. And so in this course and in this trial and education session, it was a broad definition of spirituality. So now I'm going to speak a little bit about guidelines and models. So we were involved with a number of organizations, Betty Farrell at City of Hope, Monsignor Bob Vitello at Caritas Internationalis, and other groups, in a number of consensus conferences. The background of this is I had asked Betty, research in this area is hard. How do we start establishing something? And she says consensus building is one way to do that. So we did do that. I'm going to speak first about the conference in 2009 in Anaheim, California, on improving the quality of the spiritual domain of palliative care, and I'll come back to the others. So you heard yesterday about the National Consensus Project in the United States. Diane Meyer and Betty Farrell were the co-leads of that. There's a more recent edition than what I have up there. It was just another edition. But within the required domains of palliative care, this was the first time that spiritual, religious, and existential issues were pulled out as their own domain. It used to be under psychological and social aspects. So this was a change. In that early report, the only requirement, or the only recommendation I should say at that, was that all patients should get a spiritual assessment. But they didn't say who, what, how, and when, and what to do with that. So Betty and I collaborated and invited many people for a consensus conference on that domain to say, what does that mean? What should we do? We had interdisciplinary, interfaith, atheist, agnostic, etc. Our recommendations from this process, and it was a long process where we wrote a paper, and everybody, the 40-plus people that came, contributed to that, and for the 10-page paper became an 80-page paper, and then we had a conference and extensive discussion and debate. These are the overall recommendations from this, that spiritual care should be integral to any patient-centered care system, that it's based on honoring dignity, attending to suffering, the themes we've heard from this morning and yesterday. Now here's where we talk about a little bit medicalizing spiritual distress. So spiritual distress should be treated the same as any other medical problem. And the chaplain in the room said, you ask about pain on a scale of 1 to 10, what about spiritual distress? So very, very key. And that is why we've been a little reductionistic in medicalizing it, because, as my medical student noted in the paper, terrible consequences if we ignore it. But for those of us that are clinicians, we understand we work within a medical framework, and we need to use that language. So, and I think it's important. It's important to highlight that in our programs. Some people working, Jimmy Holland, who recently passed away and did amazing work, was working on spirituality as perhaps a vital sign. Interdisciplinary, including chaplains. All patients should get a history or screening, and I'll talk about that, and then develop a whole person treatment plan. So here's the definition. I am going to, for sake of time, only use the global definition, which we're now using, which comes from one of the other conferences, but the words that are italicized are what the global group added. US did not want to use transcendent, too philosophical, hard to understand. We didn't want to put ultimate meaning. There was a lot of discussion, and ultimate hope that Anne talked about was brought up in the global group, that it is not just meaning, but that ultimate sense of meaning and purpose and transcendence. And then in the US, we talked about connectedness to self and others, but in the global group, it was experience of relationship. It's really beautiful. It brings down the relationship, so important, to self. And then especially the group from Africa felt family was important in that, others, community, society, nature, and the significant or sacred, however we understand that. So the point of this definition is that this is not just for the religious. Many times people say religious patient, refer to chaplains. No, chaplains work with everybody. Humanists, secular humanists, atheists, agnostics, and so do we. So this definition is very broad. I will tell you also in my own experience, that people may be identified with a particular religion, but what is active in their life in terms of their resources of strength or the distress may be apart from that. And so it's important that we listen to all of those stories of our patients. And then finally, in the global group, our research group in the back of the room said, we have to have a simpler definition we can study, and added spirituality is expressed through beliefs, values, traditions, and practices. Now, the National Cancer Comprehensive Network in 2007, and George Hanzo is here, was involved in that in developing chaplaincy diagnoses. And these are the diagnoses that were developed. We added and modified a little bit in that 2009 consensus conference, and now many people are using these as spiritual diagnoses. For those of you that want to know how to code for that, in the US we do have a V code for counseling for spiritual distress that many of my colleagues and myself use when we do this. So existential issues obviously are a huge part of this, and again, as Anne emphasized, chaplains are trained to deal with existential issues, not just strictly religious issues. We added to abandonment by God others as well, the significant others in people's lives, and you can see the rest of the list. So we are actively doing work right now to expand on this in our cancer population. We're doing focus groups to see how patients experience distress before we share this, how families, how clinicians address it if they do, trying to understand this a little bit more. Now, I apologize to Catherine, who I know hates slides like this, but the reason I put this up, and it's very small, it's to give you a perspective, so just look at it as a whole. Physicians, in particular oncologists, love flowcharts. And so part of in 2009, we wanted to put into this kind of a chart, what do we do for a distress assessment? So in palliative care, and we should probably in other care as well, do a distress assessment. And we need to see where the distress is coming from. Is it physical alone? Is it physical and psychological? Is it physical, psychological, and social? Physical, psychological, and spiritual? Is it spiritual alone? So the first diamond up there is no spiritual component, but maybe physical or psychological or social is present. And then in the generalist specialist, we would deal with that, but we would also engage other colleagues who are more expert, say, in counseling or in social issues. Or it's a spiritual component and one of the others. So now you have the arrows yes and yes going to working with others for the other components, but also addressing the spiritual issues, and I'll talk a little bit about what we mean by simple or complex. And then the last is spiritual issue only. So if I, as a physician, find that I do my distress assessment and I suspect it's spiritual only, so then the chaplains in our group in 2009 defined these interventions as simple versus complex. I do not think simple is simple, but for the purpose of this type of model, the simple would be that these are things that I feel, honestly, within my own training that I can address by being present, by listening, all the beautiful things we've heard this morning, by creating that space, letting someone talk about that. If it doesn't resolve, then I need to think about referring to a trained spiritual care professional or chaplain. If I hear, as I did with the patient I just described, that it's more complex, I should involve that spiritual care professional right away. So that's the purpose of that sort of flow chart, so you can understand how it works. So one of my greatest issues, I guess, I was going to say sadness, is when I visit palliative care teams in our country, and I'll ask the doctors or the nurses, how do they address spiritual issues? And they say, there's a chaplain on our team. Fantastic that there's a chaplain on the team. We should have them on every team in every single area. But not fantastic that the doctors and the nurses aren't also asking this. All of us on the team need to be doing this. So some of the tools there's screening tools that George Fischette has talked about a lot. Histories, we developed a tool called FICA that was validated with Betty Farrell's group at the City of Hope. There's Spirit and Hope as well. Those are not validated, very good tools. And those of us that develop treatment plans would be doing a history. So that would be doctors and nurses, primarily advanced practice nurses. Assessments is what's done by chaplains, and I won't go into that too much because Anne already has talked about that. So the generalist specialist model is simply that all of us on the team address patient suffering and all of us provide support. In our own team in oncology, sometimes the chaplain enters into a discussion about physical symptoms because that's what happens in conversations in these truly equal teams. Right? So we all will talk about everything of the patient. We're not artificially divided into 4 sections, but we have to be honest as to our training and who should be the person on the team that might go in depth. We develop treatment plans. I write about assessments. I say, I think this is what the spiritual distress is. And then if I work with a chaplain, that person will tell me if I'm right or not or what I should do. And often chaplains will feed back to me and say, now this is what I suggest you might do with this patient. Chaplains seek care in the US provided by board-certified chaplains or a student in a CPE program. And examples include emotional, spiritual, religious, pastoral, ethical, or existential care, as Anne talked about. Anne already talked a bit about the training. In the US, we use a clinical pastoral education training. Masters of Divinity is required. And Anne talked about the others, so I will move on. So finally, what I want to talk about are the recommended standards for spiritual care. So when I say recommended or proposed, these aren't standards that are in every hospital and people are held accountable to it. It is much as to think about how in our country we develop standards on hand washing. Initially, washing hands in the hospital so we don't transmit illness from one patient to another. There was this kind of a process where 20 or 30 standards were developed, and eventually over a process of research, et cetera, they came down to 2 or 3. So that's the notion. And the 2 conferences highlighted now in bold, one in the US in Washington, D.C., 2012, and another in January 2013 in Geneva, which was the global group. It is a result of this. And there was a very long process. We did a policy Delphi methodology to get opinions from everybody, and then meet in person and vote and discuss and go in great depth. So again, not to go through this, I believe these slides will be online, and you'll be able to see them. I'm happy to share the papers with you as well. But want to just point out what was different in the global group, a big emphasis on research. Development of spiritual care is supported by evidence-based research. And then that this spirituality in healthcare should be developed in partnerships with faith traditions and other belief groups. Again, thinking about the broad audience. The other part here, and we heard a bit of this from Sister Juliana, is that we all need to be trained in compassionate presence. And I think this is a very important part of professional development. We heard it from some of our speakers this morning, but this kind of training is new. Chaplains do this very well. And so we have, for I think now about 18 years, had chaplains who are part of our curriculum at George Washington University, and now in many other medical schools as well, to help teach this, this aspect. And then the final bullet, developing healthcare systems, developing that sense of connectedness through this area. We heard yesterday the importance of community and building connectedness. Okay, so Anne talked about standards for chaplains. Chaplains do have, as standards, we have members from the United States Professional Chaplaincy Associations here today. 5 of these, including the Canadian one, represent more than 10,000 members. They've been collaborating since the 1920s, and they have common standards. What I want to point out here is the last bullet, the implementing the 5th domain of the clinical practice guidelines of those national consensus projects. So in this latest edition of that, there were chaplains looking at domain 5 and writing that and developing that. So it's a huge, huge piece. The result of these meetings ended up in a global network for spirituality and health. That group contributed to a chapter on spiritual care in the WHO manual for implementing spiritual care. We've held several gatherings, and they're involved in a training program that I'm going to discuss at the very end. Here are some of the members, and I think you'll recognize some of the people. The tall guy in the back, Rick Bauer, John Swinton, Ann is in the front, and George Hanso, who's here today too, has been part of all these conferences, a chaplain as well. Just very briefly to talk about some of the more recent work in spiritual care, Betty Farrell has developed a nursing program called ELNIC that's now updated now 97 countries. And she's gone into different countries. In the US, this was developed very well, and since then she's been working with other countries as well. Here we are doing the spiritual history translation studies with many countries, and Father Mario Cagna here in Italy has done an Italian translation, is about ready to do some studies with that. In Europe, there's various models. Anne covered that. I will not talk about that. South Africa, pastoral counselors right now are volunteering in hospices, and at St. Luke's Hospice, there's a strong interfaith model there, no professional chaplaincy. Asia, Sister Juliana presented her program, and in Chile, we're beginning a pilot, Association for Clinical Pastoral Education and ourselves beginning a pilot in developing culturally appropriate palliative care teaching as well as spiritual care profession. And as was mentioned yesterday by Marie Boussard, building houses are different in different areas, so you can't take one program and go into another. So this is I'm very honored to be part of this, because with great humility, we're going to work with other countries and see what inspires them and how they are going to work on these issues if within their cultural context. We've also been part of different parts of the Vatican. I presented the Pontifical Council for Aging about 6 years ago for health on aging and the spiritual dimension, and models about that were brought up. The Maruza Foundation, you'll hear more about it, 2 excellent charters on pediatrics and the older adult, and of course this conference. So building collaborations. These are logos from all of the chaplain organizations in the US, the Global Network, and then Eric, you heard about from Anne. And there are many more collaborations than this, but I wanted to show how critical it is for us to partner with professional spiritual care. This is the only way we're going to really be able to implement this in a way that is helpful for patients and that can work. We are launching our first interprofessional Train the Trainer spiritual care program, ISPEC. We started this in the US, but opened it globally, and we have the faculty come from different countries, so we are making the cases culturally appropriate. There's an online component that will be available to everybody, and in April we have applications due. Here again is an example of collaboration. We are asking for chaplain or spiritual care professionals, whatever is appropriate in the country, and a clinician to come. So chaplain doctor, chaplain nurse, social worker, etc. And I am incredibly impressed that the first applications we've gotten, 3 from India. We have an application from the Netherlands. We have applications from South America, different countries in South America. So this should be very, very exciting. And again, this is a partnership with chaplains. So in closing, I want to quote Mother Teresa: "We can cure physical diseases with medicine, but the only cure for loneliness, despair, and hopelessness is love. There are many in the world who are dying for a piece of bread, but there are many more dying for a little love, for the compassion that we can bring." And so the story of a patient that I want to share is Sharon, who recently died. I took care of her in the palliative care clinic for a year. She was diagnosed with metastatic pancreatic cancer a year ago, January. And she was a very intellectual person. She had very strong family support. And as her illness progressed, physician aid in dying is legal in Washington, D.C. So she asked me that she would like to avail herself of that because she did not want to linger the way her own mother lingered when she was young and her mother died of cancer. She did not want her children to see that. So I needed to tell her that I could not do that. But I had promised her to be with her till the end of that journey. So for me, it was a very emotional case, actually, to think, how would I be there as I watched another physician give her those pills? But I was going to be there for her. So in the process, I explained to her about palliative care and about hospice, and the notion that we can't control everything, and we need to keep room open for mystery, because we don't know. And I also assured her that the physical symptoms she was most concerned about could be handled. So I was able to work with one of the best hospice nurses in DC, Valerie Martin, and I worked together a lot. And so she was in hospice, and the question about the physician aid in dying did not come up. And I decided to do a house call. I was scheduled to do one, so I went to her house on a Sunday, and she has a huge family. They were all in the living room, Everybody was talking, people were joyous. I walk into the bedroom to see her, and she said, "Dr. Puchalski, you were right. A terrible wound in my family was healed today. If I had not been here, that wound would not have been healed." And we hugged and we held hands, and her husband was there, and she was a nurse who taught end of life, and I asked her what she taught. She goes, "I taught my nurses to allow for spooning," that's an American term, but to let people hug the dying. So that night I went home and her husband texted me, "Sharon and I are spooning tonight," and she died the next morning. That is what palliative care can do. That is what can happen when we include spirituality in palliative care. Palliative care and spiritual care are human rights, but if we do not have excellence in spiritual care and we do not have professional spiritual care providers, and if we all don't address it, we cannot provide quality palliative care. So I ask you all to please join us on this journey to be sure that spiritual care is included in palliative care, and I thank you all for the work that you do and for your attention today.